It is my pleasure to introduce you to today's speaker, Ms. Rhiannon Reese. Ms. Reese is an LPC, a nationally certified counselor who holds a bachelor's in psychology and an MA in clinical mental health counseling. She currently serves as the clinical director of crisis services for the Crisis Center. Ms. Reese is a gifted trainer and loves providing her support through supervision and guidance to the Crisis Center's clinical staff and volunteers. Her roles through the years include crisis counselor, rape response advocate, prevention educator, and grant writer, and all of these give her a full scope of the work of the Crisis Center. So please type any questions that you have in the Q&A box, and we will answer those. She will answer those as we go. Ms. Reese, the mic is yours.
Thank you so much. I appreciate it. Thank you for having me. I'll give you a little bit of information about the Crisis Center. If you're not aware, we are located in Birmingham, but we serve Jefferson, Blount, St. Clair, Shelby, Walker, and Chilton counties for crisis services. And then Jefferson, Blount, St. Clair, and Walker for rape response or sexual assault services. But what we do is 24-hour crisis intervention, mostly over the phone. Our sexual assault survivors can come in person, but otherwise we're here to help anybody who's in crisis. One of our programs, I think, is especially relevant to what we're doing today, which is the Recovery Resource Center. It is a one-stop shop for people who are looking for help with substance use issues. So it can be the person who is experiencing the issue can go there, they can call, they can get an assessment to determine level of care, and then get placed on a waiting list for whatever resource is available to them, and then get linked up with a peer support specialist, so somebody with that lived experience of being in recovery. I think the program had been open for about a year when COVID happened. And so we really had to figure out, what is this going to look like? How do we continue to serve people? They met their yearly projected goal in the first 3 months. So we knew that it was a needed service. So part of it was to transition to all telehealth or virtual services. We didn't do anything in person for over a year. So I'm not the expert I really feel like the expert on very little of anything, just a lot of little things that I know about. But I can tell you anecdotally, what our experiences have been and how effective it has been to serve people who are struggling with substance use. There we go. So our objectives today, we're going to talk about the differences between effective, how is telehealth helpful? Is in-person going to be the most helpful thing? I don't think there is a definitive answer that yes, one is better than the other. I think that it's circumstantial. It just depends on the situation, but we're going to talk about it. I'm going to help you understand the value of building relationships and building rapport, especially when working with people virtually. When you're in person, a lot of things are much easier, and there are some limitations to services when it's virtual. We're going to talk about some of the skills necessary for building those relationships. For most of you, I think that it's going to be a review of what you know. You may not have just given it a name before. So especially for the mental health providers, y'all know this stuff, you've been through it. But for the medical professionals, you're probably already doing it, and now we're going to give it a name. So it might be a little bit easier to be intentional about it. And then finally, we're going to talk about some culturally competent strategies so that we can communicate effectively. This is going to be in general, general cultural competence and not necessarily specific to telehealth, but it's especially important when we're doing telehealth or virtual sessions. All right, so there are definitely some benefits and limitations to providing telehealth or virtual sessions. Talking about the benefits first, the first one, probably the most important, especially when COVID started, was no disruption of care. I can tell you anecdotally that the counselor that I had been seeing I want to say that I've been seeing her for about 13 years. If I had not been able to talk with my counselor virtually, I don't know what I would have done. So I can say that for me personally, this was really, really important. So I know that in talking to people on the crisis line and working with people through the Recovery Resource Center, it was really important to be able to continue services, and telehealth and virtual was the only way for us to do that. Many people like telehealth. just because it's convenient, it's easy to access. You don't have to leave work in order to go to an appointment. You can, if you want to sit in your car and have a session or talk to your mental health or medical provider, you can. It's really, really easy and like way fewer disruptions to your day. My husband today he works in Hoover and had to drive all the way back to Southside to go to the dentist. And I was like, if only dentists could do virtual stuff, but that's one of the situations where that's just not going to work. People with mobility issues really appreciate telehealth. Um, I know a lot of our facilities are modern facilities, and we, adhere to the ADA standards in order to make things accessible for people. But for a lot of us, we are in old buildings. We've been grandfathered in. We don't necessarily have accessibility the way that all people with mobility issues might need it. And so it can cause a lot of anxiety when a person with a disability, especially a physical disability, is trying to figure out how do I get here? Where do I park? Am I going to be able to get inside? So being able to say you can visit us virtually makes it a little bit easier and maybe reduces anxiety for people. Additionally, it's quick, it's easy access. If you need an immediate appointment, you can hop on the computer. I know that now our insurance has telehealth, and so when I schedule an appointment, it's usually within about an hour, and I get to talk to somebody versus calling to make an appointment or going over to one of the freestanding clinics. It makes things really, really quick. People get seen really easily, and they feel supported. Some of the limitations, there are definitely limitations. Some of this we can overcome with building those relationships, and others it's going to be a little bit more difficult to provide telehealth at all. So one of the limitations is that people like to see each other. We feel comfortable around people. My 7-year-old, I don't have any evidence to back this up, but my 7-year-old told me that when people are in the same room together, their breathing starts to mimic each other, and their heartbeats start to mimic each other as well. So in the room with each other, we can help each other calm down. We can help each other feel safe. I love that. Again, it was a 7-year-old that said it. It's possibly not true, but the medical professionals would know better than I would. Telehealth is not appropriate for all conditions. Even at the crisis center, there were some things that we couldn't do virtually. So many of our programs switched over to virtual or continue to be over the phone. Our sexual assault support services, we can do counseling over telehealth. We can't do sexual assault exams over telehealth. It would be inappropriate and ineffective. And so there are going to be times when, as medical professionals and mental health professionals, you need to see your people in the office. So I think as long as we don't try to apply this to every situation, I think that we can make telehealth and virtual stuff work in many, many situations. But of course, there are limitations. Insurance has been an issue for a lot of people. Sometimes insurance companies won't reimburse for telehealth or telemedicine. They have a lot of requirements that you maybe didn't previously have to deal with if you were offering services in person. Another issue is the liability when, especially this is for my mental health people, when we're working with a client, if it's over telehealth, we have to be able to know where they are, what their location is, so that if there is an emergency, we can dispatch somebody. There also the issue of license portability. So I'm licensed in the state of Alabama. That means that I can only practice within Alabama. If I try to practice counseling on telehealth with somebody outside of Alabama and something goes wrong, I could get in big trouble. So there are definitely liability issues and just being able to offer services. One of the other things that we ran into, so we've offered over the phone crisis counseling for 50 years. The Crisis Center has been open since 1970. So we know that it's effective. We know that it's helpful. But what we were noticing that when we started to do telehealth, especially for counseling clients, that while people have access to the phone, they don't necessarily have access to the internet. And if they do have access to the internet, it could be that it's, we're paying by the minute. It's not really to their benefit to do telehealth sessions if their internet is not good enough to get where we need to be going. So as we work through the training today, just remember that there are going to be situations where what we're doing is not going to be appropriate, and then other situations I think that is really going to translate beautifully. All right, I have a video that I would like to show y'all really quickly. Hopefully, okay, there it is. I'm really proud of myself for embedding it. I typically have to get somebody else to do it, so I was really proud. This is an explanation it's an explanation of the difference between empathy and sympathy. Brene Brown is a social worker and a shame researcher, which is, I mean, I couldn't do it, but I'm so grateful that she exists because she does a lot of wonderful stuff, especially in mental health. But she explains the difference between empathy and sympathy. And as we start to work through all of this, we're going to find that empathy is so vitally necessary for what we're doing, and that sympathy sometimes can drive disconnection, which is not what we want when we're doing telehealth. So we're going to watch this. It's pretty quick. And if you're interested in Brene Brown, you can just Google her. She's everywhere. All right, there's no sound. Can y'all help me with that? There we go.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. Yeah. And we do it all the time. Because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So, I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now, I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
All right. I may or may not be obsessed with Brene Brown, so please shout out on the chat if you also love Brene Brown. If you don't like Brene Brown, you don't have to tell me. I love her stuff. She has written a ton of books about many different issues. One of the best ones that I've read so far is Dare to Lead, and it's about bringing vulnerability into your leadership. And I think that vulnerability, unfortunately, is a really necessary skill when we're working with people who need our help, who need that connection with us. So we're going to talk about some of the skills. So this is adapted from our volunteer training. So this is the way that we teach our volunteers to work with people, especially over the phone. We try and talk about the difference between like connecting with somebody on the phone and in person. And we talk about what are the most effective ways to communicate in order to build that relationship and how important it is. So when we, I feel like probably in every program that we've been in, this is a group of professionals helping professionals. We were taught how to attend to people, how to make sure that they knew that we were paying attention. Things get a little complicated when you're on the phone or when you are on telehealth. some of the things that we would normally do, like make eye contact or mirror body language, control our gestures to make sure that we're not, if somebody has an exaggerated startle response or is feeling anxious, um, monitoring our tone to make sure. Sometimes we have to be a little bit louder on the phone or on virtual. So the things that we can do when we are working virtually with somebody is make sure that we have ear contact. So eye contact, that's easy, but I'll tell you a secret on webinars on telehealth. We're all looking at ourselves. None of us are looking at the person that is providing services. We're looking at ourselves. So we have to make sure that we're providing ear contact, because people can't tell if we're, having eye contact with them. So ear contact is just making sure that we are doing what we call cooing, or putting noises to the actions that we make. I find myself, when I am on the phone with people, if I'm on the crisis line, I do a lot of nodding. And I have to remember, they can't hear you nod. So saying, or I see, or I understand, just making sure that we are communicating, that I'm communicating, that I'm on the same page. It is very frustrating when you're working with somebody and it feels like they're not really on the same page, or they're not attuned to you. So to make sure that when you're on telehealth, if you're doing something virtual, have that ear contact, that we call them coos or attending skills. Your body language. So even if you're doing something virtually, it's really important that your body language is pretty similar to what you would have if you were in person with someone. Sitting up straight, sitting up squarely, making sure that our feet are flat on the ground and we're not kind of like kicked back and relaxed. In telehealth, that's pretty easy because people can see the camera. But if you're just on the phone, it's hard. It's hard to make sure that your posture is, as professional as it normally would be, but people can hear it in your voice when you're not engaged that way. Gestures, when we're working with people in person, we have to make sure that we're not like wildly gesticulating, just because that can be overwhelming to somebody maybe who's experienced trauma, or somebody who is dealing with really anything. So I talk a lot with my hands. So in person, I have to make sure that I keep those to myself. But then when I'm on the phone or on telehealth, you can't see my hands. So if I'm doing something to let you know that I'm understanding, I have to make sure, again, to try and find a noise that fits with it. I also find that it's a little bit more difficult to pay attention when you're on the screen with someone or on the phone with someone versus when they're live in your office. So a lot of times I need something in my hand to play with or fidget with. I should buy stock in paper clips, because I have so many paper clips that I have unwrapped and thrown away just because I can't use them anymore. So I undo a lot of paper clips. So just finding what works for you. Sometimes doodling helps. Just whatever works, helps you pay attention, is really important. And then finally, tone. I've got my presenter voice on right now. I am speaking probably a little faster than I normally would be if I were in a session with someone. I'm speaking a little bit more, I would say assertively, not aggressively, but assertively. Whereas if I am providing services for somebody, like mental health services, I'm a counselor, I might slow my voice down a little bit and then try to adjust my tone to make it a little bit softer, a little bit lower. Again, this is my 7-year-old. If you're in person with somebody, the way that you can get people to kind of engage with you and calm down is to be in that same room. Your breathing mirrors each other and your heart rate starts to mirror each other. But there is also a theory that your tone, if you speak in a slow voice, can help somebody else calm down as well. So those are really important. These are not things that I think I can physically show you. I can tell you about it, but it just takes practice to do it. It's likely that you're all already doing this. You just didn't necessarily have the phrase ear contact to go by. Oh, wait, not yet. I'm going to come back to those. I think I wanted those later on in the presentation, so I'm just going to hop back to them if that's cool. Okay. All right. So the next skill is open-ended questions. So open-ended questions are just questions that require more of an explanation than a yes or a no. You are going to have some clients and patients that if you ask them a yes or no question, they're going to give you a dissertation on the answer, right? So if you ask me a yes or no question, I'm going to open it up myself and tell you everything that I've ever wanted to tell anybody, because I like to talk. There are also some clients and patients who maybe are feeling vulnerable or feeling overwhelmed, that if you ask a yes or no question, that's what you're going to get is yes or no. And we maybe need more information than that, or we need them to tell us more about what's going on versus us asking a million yes or no questions to get to an answer. When you ask open-ended questions, it just means that it doesn't require a single word answer, and it requires the person you're talking to reveal a little bit more about the situation. When you're asking open-ended questions, we want to do our very, very best to avoid why questions, because it puts people on the defensive. When you ask people why questions, very often it makes them feel like they have to defend how they're thinking or feeling or acting. And that doesn't feel good when we're trying to build rapport with people. We do presentations, we do trainings for law enforcement who work with survivors of sexual assault, and we are training them not to ask why questions. If they have a question, they can reframe it into not a why question. So why did you go to that party can be reframed into, tell me more about your relationship with the person that threw the party. How did you get there? If they want to know, why did you take a drink from a person you didn't know? They can ask more like, tell me about your relationship with this person. Are they somebody that you trust? Right? So instead of like, why, putting people on defensive, you're asking those open-ended questions and you get more information anyway. If you feel like you're doing all the work, if you feel like working with your client is like pulling teeth, it's probably because you're asking, closed questions. But that just really is something that you have to be self-aware and know that, okay, I need to rephrase this. But there are definitely times when you need to ask closed questions. If there is an emergency or you need information really quickly. When you are working with somebody who, especially if they're not in the same room as you, and you need to determine like if they're stable, you can ask those yes or no questions to get to somewhere really quickly. Most often on the crisis line, we ask yes or no questions when we are trying to assess emotional stability and suicidality. So we need to know yes or no, do you have a plan, versus like, tell me more about your plans for suicide. We don't need somebody to spiral. We need a simple, straightforward yes or no so that we can move on to the next question. One thing I like to tell the volunteers is that nobody's going to come and like slap the phone out of your hand if you ask a yes or no question. It's not going to endanger your relationship with that person. It's just going to make it a little bit harder for you to offer the support in the amount of time that you have to see somebody. Crisis line calls, we can take pretty much as long as we want to, but I know that as mental health professionals, medical professionals, y'all typically have a limited amount of time with a client or patient. So it's important that we get to the meat of it really quickly with those open-ended questions versus asking a million closed questions. One of my very, very favorite things that we teach the volunteers is reflection. So for the mental health professionals that are on the webinar today, y'all know this, you know the words for this. Medical professionals are typically not taught this. We have a good number of medical professionals on our board of directors at the Crisis Center. And our most recent president, he wanted to go through crisis line training and take calls, and he's a physician at Children's Hospital. And so we were going through the training, he was learning reflection, he was practicing it on the line, and he decided to use it when he was doing his job. And he came back and told me, he was like, I realized that I had been doing it, I just didn't have a name for it. Now that I have a name for it, I can do it intentionally. It makes me feel like I'm connecting with people better when I can reflect back to them that I understand what they're saying and that I'm interested in learning more about what they're saying. Reflection can be really difficult if it's not something that you typically use in your everyday communication. Most of the time, if you try to reflect with a friend or family member, they're going to, look at you funny and say, what are you doing? Why are you asking me that? But when you're working with somebody in a professional setting, asking questions and reflecting information can deepen your connection with that person because it's showing them, I want to understand. I'm listening to understand. So when you reflect back what somebody says, you essentially take your understanding of what they said and give it back to them. It requires empathy. Empathy, the definition of empathy can change depending on who you're talking to and what their profession and what their focus of help is. But empathy is typically taking the point of view of the person that you're talking to and then giving it back to them so that they know that you understand. That's what reflection is. You're showing, this is how you show somebody, I am empathetic towards what you're experiencing. Reflection is really helpful because it helps people feel understood. And a lot of times when somebody is in crisis, if somebody is coming to you for services, that's usually what they need. They need to know that you understand what they're going through and that you can help them appropriately. When we reflect, we can do it in a couple of different ways, whatever works best for you. I'm going to tell you the different types of reflecting and then some kind of reflection prompts that you can use. But the first one is verbatim. You can say exactly what the person has said to you right back to them. So this one would be, so if somebody says, I just don't know what I'm going to do, I feel trapped, you can reflect back, I just don't know what you just don't know what you're going to do, you feel trapped. This one don't do it all the time. Don't like only constantly reflect verbatim, but this is one that you can use interspersed with other reflections. But sometimes the person has said something so succinctly that all you can do is reflect it back verbatim. Another one is to paraphrase what the person has said. This is typically how most people reflect, but you take what the person has said and then change the wording a little bit. You may change the intensity of the emotion that they're expressing to see if their emotion is that intense. But a lot of times reflection is just tentatively seeing, like, am I right in assuming that this is what you're saying? So for example, I just don't know what I'm going to do. I feel trapped. You can reflect back. It sounds like you're at a loss as to what to do because no options seem like the right one, right? So we are changing a little bit, maybe deepening a little bit and going forward from there. For the mental health professionals on the call, you all know reflection of feeling and reflection of meaning. The great thing about this is that for everybody out there, nobody's going to say, okay, well, you reflected, but can you define the way that you reflected? That doesn't matter. We don't need you to know how you did it. We just need you to do it. That's about it. So reflecting feelings is you take the emotion that you're identifying in what the person has said and reflect it back to them. So for example, if somebody says, I don't know what I'm going to do, I feel trapped. You feel anxious about your next steps. You sound scared. You're feeling frustrated at not knowing what to do next. So take whatever emotion you think that they're feeling and then reflect it back to them. If you get the emotion wrong, nothing bad happens. They can just say, no, that's not quite it. It's really like this. And so what you're doing is really helping them narrow the focus of what's going on so that you can better assist them. Reflection of meaning or content. This one is just taking your understanding of what the person has said and reflecting it back to them. So I just don't know what I'm going to do. I feel trapped. It sounds like you're unsure about your next steps. We're not bringing emotion into it. So if emotion is not something that you want to discuss, if a person doesn't seem like they're very comfortable with it, you're going to reflect content or meaning. The great thing about reflection, it's respectful. You're mirroring what they are saying and showing them that you're really on the same page. Many people, especially those suffering from mental health conditions or substance abuse, have been told that what they think and feel is not right or that it's not important. So as you reflect to them what you're hearing, you're showing them, I care about what you have to say. It's important to me to understand what you're going through. It shows that you're paying attention. We can't help unless we're paying attention, and it is really easy to get distracted when you're on telehealth, when you're virtual, when you're not in the room with somebody. They can't see what you're doing, and it becomes really distracting. So making sure that we're reflecting means that we're paying attention, we're listening to understand and really be able to say, this is what you need help with. If you concentrate on what the other person is feeling, it removes the need for you to put your own feelings or judgments on something. If you're really trying to empathize with them, then you get out of your own head and try to get into theirs. Okay. All right. So these are some reflection formulas. You don't have to, like I said, you don't have to be able to define or tell us like which one you're using, but just knowing that you can use these formulas makes it a little bit easier for people. A lot of volunteers, a lot of mental health professionals, they use when blank happens, you feel blank. This is when situation or action happens, you feel emotion. I'll be honest with you. I've been doing this work for, I can't even remember, over 15 years. I am not good at this one. My brain does not work fast enough to pick out the emotion and the situation and put it into a formula. If your brain works this way, high five to you. I'm very proud of you. Please continue to use it, but I can't do that one. I am really good at it sounds like. So it sounds like, and then you say what the person, might be feeling. So if you're doing the when blank happens, you feel blank, you would say the situation could be not knowing what to do, and the emotion is maybe frustration. So when you don't know what to do, you feel frustrated. It sounds like it's just adding it sounds like onto a reflection. So it sounds like you're feeling nervous. It sounds like you're feeling stuck. It sounds like you're feeling scared. And then finally, what I'm hearing you say is, it's just another, it sounds like. Be careful with this one. My mom told me that when I use the words, what I'm hearing you say is, it means I'm about to start an argument. So I don't use this one anymore, just so that I don't sound aggressive. So thank you, Mom, for letting me know that I'm aggressive. So what we're going to do now is I'm going to go back to the polls from before. All right. So to give you a chance to practice, I'm going to read you a statement, and I want you to choose the appropriate reflection and the appropriate open-ended question. So the first one, When you get older, I guess you have to expect things like this to happen. I broke my hip when I fell, but it could be a lot worse. Being in the hospital is a pain, but I guess I'm glad to be able to go to the hospital. So can y'all, I'll give you a couple seconds to read it over. Can you check, click the one that you think would be the most appropriate answer? Ellen, will it pop up? I've never done a poll before. So will it pop up or do I need to do anything?
You just tell me when you're ready for me to share the results.
Okay, cool. I feel like probably everybody's chosen. Will you share the results? Good job, everybody. So, of course, like any response to this, like as long as you're not telling the person, like, well, this is your fault for doing this, I think any response would be appropriate. But letting somebody know, like, I hear that, I hear what you're saying. It's hard to be in the hospital, but at the same time, you're also grateful that you can come here. I think it's going to get you a little bit more connected to that person because you are recognizing what they're thinking and feeling. I love, thank you. Nobody chose why. Thank you for not choosing why. So choose an appropriate question that you could ask. Tell me more about what happened. So it's open-ended. We're not saying like, why did you climb up that ladder? Don't you have somebody who can help you? Making them feel as though they shouldn't have been doing it in the first place. So just let them know, hey, tell me more about what happened. Good job. All right. So the next one. All right. So poll number 2. It was all I could do to come here. A friend told me to call the police, but then I become one of those stories you see on social media, or they'll be asking me all questions and blaming me. I just want to forget it. I don't want to keep reliving it over and over. Oh no. So it looks like some people can't see the questions and answers. I'm sorry, Kay. I bet you would have done really well on it though. All right, I bet we've probably had enough time to vote if you want to reveal the answers. Good job. Excellent. Everybody chose the same ones. I'm very impressed. So it sounds like you're feeling really scared about what happened and that you don't want to have to keep talking about it. So that's a perfect reflection because you're not at what you're hearing is that this person doesn't want to keep talking about it. So if you demand like, well, tell me what happened. Why did you come here if you didn't want to talk about it? Or telling them what to do or giving advice. This is a really good reflection because it helps them know I'm not going to tell you, I'm not going to get you to tell me about this if you don't want to. Of course, like in your professions as a medical professional, like you really do need to ask questions about what happened. But there are times when you can build rapport first. And then because you aren't forcing somebody to answer a question, they might feel more comfortable to open up and tell you more. So the appropriate question everybody chose, what is the best way that I can help you work through this? So instead of like, what are you expecting to happen? Or why did you come here if you didn't want to talk about it? We can tell them, what is the best way that I can help today? Good job. It sounds like y'all really understand what I'm putting down. Excellent. All right. So I want to be mindful of the time and definitely get to talking about the cultural competencies. So I'm going to talk really quickly about the roadblocks to effective listening and things like people are really worried they're going to say the wrong thing. So I'm going to tell you all the things basically not to say in order to be a good relationship developer. So when we hear something, we typically are going to have the idea that we need to judge or evaluate everything that they've said. We will take our knowledge of the situation and then because we are wise and we know what we're talking about, reflect it back to them. But instead, if we're listening to understand, we don't put a judgment or an evaluation on what people say. We let them talk about what they need to talk to. Another roadblock is when we jump to conclusions or try to fill in the blank, and we don't let people, explain exactly what they're going through, but instead we assume that we know what's going on. We can avoid jumping to conclusions if we can do some good reflections and good open-ended questions because we trust that the person is the expert in their life. Another thing that keeps us from being good listeners is that we assume that a values or belief system based on our own values or belief systems. We assume that people think the same way that that we do because we're reasonable people. My assumption is that everybody votes the same way, or everybody, likes all the same things because I'm a reasonable person and you are too. But it turns out people can be reasonable and be different. So we have to make sure that we're not assuming that somebody's values and beliefs align with our own, and that we have to be respectful of those values and beliefs and be open to hearing about them. A closed mind. This one it's hard because we're pretty well established in our feelings. And so when we hear new ideas or new thoughts, we might not be open to them. Again, the great thing about reflection is that we don't have to agree with what the person has said or even think that what they said made sense. We just have to reflect back that we heard it. I suffer from this one, a short attention span. When you're listening to understand, when you're reflecting and asking open-ended questions, your short attention span won't even come into play because your brain is constantly working on making sure the person knows, I am here for you. This is important to me. When I say wishful thinking or wishful hearing, a lot of times that means that we hear things that maybe give us pause and make us think, I need to assess this. Or if somebody says something related to suicide, we might think, well, they talked earlier about going to work tomorrow and looking forward to their kid's baseball game. They're not thinking about suicide because they wouldn't be thinking about that stuff. So sometimes we hear things and we hope that what the person meant was not about suicide, not about something that is going to be really important for us to be able to assess immediately. So we have to get rid of that wishful hearing and ask those hard questions. I think probably everybody on this call today has had to ask the question, are you thinking about suicide? It's a hard question to ask because we're afraid of the answer, but it's important that we do it. Another roadblock is the inability to be quiet. I don't know if y'all have noticed this about me. We've known each other for only about 40 minutes, but I like to talk. I talk fast. I talk a lot. This one affects me. I think that what I have to say is important and I want you to hear it too. So when you're working with somebody who's in crisis or somebody who is coming to you for services, really working on letting them be the experts and them drive the conversation is going to make it a lot easier for you to build that relationship. So we have to be quiet sometimes. Another thing is the semantics. So somebody using words in a way that we know is not the actual way to use the words. This one is really difficult because we like to use words the right way. So if somebody is mispronouncing or using a word that doesn't fit in the context of what they're talking about, it's okay. If you know what they're talking about, you don't necessarily have to say, okay, well, I don't think you know what that word means. So just let them know, I'm here, I hear you. If there is something you don't understand, you can say that. Say, I'm not familiar with that word. Can you help me understand what you mean? This one is especially helpful for, I talk to a lot of young people on the phone and I don't understand half the stuff they're saying. So I have to say, I'm old, please help me. I don't know what that word is. So they laugh at me. As a rape response advocate, I've heard many, many different words for vagina that I've had to say, what does that mean? So don't be afraid to ask. And then finally, fear of being changed, fear of being challenged, fear of hearing something that you don't want to hear. When we are the helpers, we have to be brave for our clients and our patients. We have to be ready to step in and be the hero. So we can't let fear override what we want to do to help people. Other things to avoid, ordering, directing, or commanding, you have to do this or you should do this, telling people like how to fix things. If you are reflecting and asking open-ended questions, you're probably not ordering or commanding people. Warning or threatening, like if you do that, you'll be sorry. That's not necessarily very helpful when you're working, especially people that are, like have substance abuse issues. They know that it's not helpful, but telling them that's not going to help you at all is not going to be helpful. But if you can reflect back, it sounds like you're having a really hard time right now. Tell me how I can help you. Moralizing or preaching, telling people what they ought to be doing, is typically not very helpful. But again, if you are reflecting and opening questions, you're probably not doing that. So labeling and diagnosing. So as medical professionals, I know y'all can diagnose people. But mostly what I mean is, just making sure that we are not like assigning things to people based on what they've said and not based on like telling somebody, it sounds like you're feeling jealous. Sounds like basically that's it. Like y'all diagnose all you want to, but as like at the crisis center, we can't diagnose. So we have a diagnostic impression, but that's about it. And then finally, one of the least effective things you can do in crisis intervention or working with somebody in general is reassuring or minimizing, telling them everything's going to be fine. This is not a big deal. What we need to do for people is normalize without minimizing. Let them know it's okay to feel this way, but I promise that you're not alone and I can help you through this versus everybody goes through this. You're fine. When we reassure, definitely like with your friends, your family members, reassure, tell people to keep that positive attitude and you got this and I believe in you. But when you're working with people that are not part of your close support system, it could sound minimizing, it could sound patronizing. So we want to make sure that we are telling people it's okay to feel this way. I know it's a scary emotion, but I can sit here in it with you. And please, if y'all have questions, please ask. I have a lot of information that I'm trying to give you, so I'm getting through it quickly. But if you have a question, something specific, please let me know. I love to answer questions. All right, so this is just a quick, I just wanted to show you this. This is how we handle crisis calls. This is a really effective way for us to give structure to a phone call or a video session. Sometimes it feels like when you're on the phone or when you're doing stuff virtually that we don't have the same structure that we have when we're in person with people. So this is kind of what this is our philosophy. We arranged it like the food pyramid. So think about this as like up down here under established rapport, those are our leafy greens. We have to eat that stuff because it keeps us alive. It keeps us healthy and strong. If we don't have this foundation, nothing else is going to stack up underneath it. So when you're working with people, the most important thing that you can do is establish that rapport. Use those attending skills, the cues, the ear contact, making sure that your body language is appropriate, asking open-ended questions, doing reflections, all of that builds rapport. And the thing about it is that if you start to get closer to like ending and you feel like you need to go back and build rapport, go back, repair the base. There is no shame in repairing the base. Once you've established rapport, you might have an idea about what the issue is. I'm really frustrated by crisis in general because crisis doesn't care if you've got other things going on, right? It doesn't mean, you've got it going on, it might come back later. Crisis doesn't do that. People who are struggling with substance abuse don't have the luxury of putting things on hold and then coming back to it later. Like we've got to address it right now. So we know that there's a ton of stuff going on, but is there one thing that we could work on today that could help us move a little bit forward or be better able to deal with the situation that's happening? So clarifying what that one thing is. What is the goal of meeting today? What is the goal of this session so that we can move forward? Once you've clarified the problem, you can explore the resources. A lot of people think resources are just going to be like referrals and other agencies that can help. But resources means who's in your support system? What do you do for self-care? What have you tried already? What are you capable of doing? What are you willing to do? And then, of course, like if there are resources that would be appropriate, if a referral will be appropriate, definitely refer. But know that we can explore those internal resources first because those are the first things that we have in our arsenal of care. Once we've identified what the resources are, we can come up with that plan of action. The plan of action at the crisis center, we use MAPS plans. Y'all might use different kinds of plans, SMART plans. I like MAPS because it's measurable. It anticipates barriers. It is positive and it's specific. So measurable just means like we can identify whether or not we have done it. It's not an abstract feeling. It's very specific to what we're talking about. We anticipate the barriers by saying, what would stop you from being able to do this plan today? What are the things that could make it impossible for you to do this? And let's come up with alternatives. The third is positive. I don't mean like make it like rainbows and sunshine and everything's going to be fine. I mean additive rather than prohibitive. What can they do or should they do versus what should they not do? So people, especially when they're struggling with substance abuse, a lot of people tell them, well, just don't do drugs like that. Awesome. Yes, that would be great. We know that's not how it works. So if we tell somebody don't do drugs, what we're doing is taking away their self-care. We've got to come up with something different. So what can we do the next time you feel like you want to use? What is one thing that you can try to do before that? It works really well, especially when there are coping skills that are unhealthy, like self-harm, drugs and alcohol, reckless behavior, risky behavior. If we can try to do at least one thing before we do that, what is something additive? What can we do instead? And then finally, wrap up. So this is very little because that's what your wrap up needs to look like. Once you've established rapport, figured out the problem, explored the resources, come up with a plan of action, your wrap up should be really quick. So how are you feeling now as compared to when we first started talking? Can you repeat back to me what your plan is? And then scheduling follow-up if they need it. This is not going to be appropriate for every of your telehealth situations. But if you need to add some structure to what you're doing, this is really appropriate. It's not, of course, not drawn to scale, but it really does represent you spend the most time in establishing rapport, the least time in wrapping up. All right. So before we move on to cultural competencies, does anybody have any questions related to the skills that we need to build rapport? We did get one question. It was more of a comment. She said that when her daughter goes to Vanderbilt for school and she has telehealth, she drives over the state line, parks, does her telehealth. I mean, that's how you have to do it. Like if you want to keep working with the professionals that you're working with, that we have to. So if I told my counselor, if she moves out of state, I'm coming with her, because I'm definitely I'm gonna act out if she ever tries to leave Alabama. So you can tell her I said that too. She's the best. All right. Well, I'll keep checking the Q&A. So if anybody has questions, please ask. So when we talk about cultural competency, we can't be competent in somebody else's culture because it's not our culture. We can have understandings. We can work hard to try and understand what that person is going through, but we can't be 100% competent. But there are things that we can work towards, like skill building in ourselves to be better able to show cultural humility. These domains of cultural competencies are also split into some kind of aspirational competencies. So we're talking about like the attitudes and beliefs, knowledge, skills, and actions that we have to take in order to be competent in each one. But I'll just give you an idea about what this means, like self-awareness. So being aware of your own attitudes and beliefs and how they might influence your relationship with your client, or your client or your patient. Knowing that, like being aware of the way that power and privilege interact with marginalized populations, being aware of the power that and privilege that you hold and the ways in which you identify in marginalized situations. Almost everyone has some way that they identify one of their identities. If we're talking about like intersectionality, one of their identities at least is from a privileged point of view, and at least one is from a marginalized point of view. And some people have a lot more. A straight, white, Christian male is going to hold a lot more privilege and a lot more power than anybody else. But then everybody, we might have intersections of those identities. So just being aware of it and knowing how it could impact your relationship with your client is really important. The ways that you can do that, so seek out continuing education, make sure that you are aware of some of the theories and the models of working with people from different cultures. The next stage is the client worldview. So understanding how oppression and how discrimination may have influenced your client's worldview, and being aware of how your attitudes and beliefs may impact that as well. We know that the client is the expert in their life. Y'all are the experts on many, many things, but the client is the expert in their life. So trusting that their lived experience is true and that they have that humanity is really important. Finally, the relationship level. So just making sure that, or being aware really that your values and beliefs, your client's worldview, all of that is going to work together to kind of form that relationship. So know that your status as a privileged or marginalized person and their status as a privileged or marginalized person is going to influence that relationship. Part of that is being able to talk about things that are uncomfortable, like stereotypes, talking about privilege and power, talking about what their past experiences are as it relates to a session with somebody. Being able to have those conversations is really important. It's really hard, but it's really important. And then finally, advocacy. Just knowing that when we are aware of our values and our beliefs, we trust our client's worldview, we know what's going to impact our relationship, our appropriate interventions and our advocacy, it's going to come together and it's going to make a lot of sense. I could spend hours talking about this. In grad school, we did an entire course on cultural competency. So to break it down into like a small session, it feels like we're not really getting into the nuances of it. But just know that if you can Google cultural competence and you can learn more about all of these different, like the different domains of cultural competency and then the aspirational goals. So talking, we have perfect. Okay. So this is my last slide. And then afterwards, I'll be available to answer any questions. But I wanted to talk to you about specific populations. And again, this is not necessarily, just specifically about telehealth, but in general, when you're working with populations who are culturally or ethnically or religiously different than you, it's really important to keep some of this in mind. So some of the people that you're going to interact with, first thinking about age differences, this is really from the point of view of an older adult, but know that like younger people also may have issues in working with people who are different than them. So older adults, some of the concerns they have is, this is personal. I don't share it with just anyone. There are many people, older adults who come from a generation where you don't share stuff that's personal, like medical history or mental health history. If you've got somebody in your family with substance abuse issues, if you're struggling with it, we don't talk about it. We keep it to ourselves. And so going to see somebody about it could be really difficult. People who are older who don't necessarily have the same access to or awareness of like other resources that are on the internet, they may be concerned, is this the right thing for me? Am I going to get what I need as a person out of this? And how do I know am I going to be taken seriously? Are people going to think that it's just dementia or that I'm just old and they're not going to take me seriously? Those are some of the concerns that older adults have, especially when working with people with disabilities. This is, again, could be an entire presentation all by itself. But in working with especially substance abuse, knowing, does this person understand my disability? What assumptions they have about my disability? Do they think that my disability caused the issue that I'm having right now? Are they going to be able to treat me outside of my disability? Is this what the person's going to focus on? And they want to know, will this person take me seriously? Or are they going to blame what I'm going through on my disability? People from the LGBTQ community, we know, have higher rates of suicide, higher rates of sexual assault, and are very, very often, because trauma does inform the way that we deal with substance abuse, there's a lot of trauma there in the LGBTQ community, which can result in drug use. So know that people who are in that community may have concerns about going to certain treatment facilities, seeing certain doctors because they don't know what to expect, or the expectation that they need to stay closeted to receive care could prevent them from getting care at all. Also, knowing what a person, like their assumptions about the LGBTQ community, do they respect my life? Do they think that I'm wrong? Do they think that I'm not a human because this is who I am? So people have a lot of concerns and they don't necessarily bring them up. But know that like the LGBTQ community, this is one of the identities that you don't wear on your sleeve. An age difference, you can usually see people's disabilities. Race and ethnicity, it's pretty obvious. But for people who are LGBTQ, it's something that if they do disclose, it's a pretty big deal. Race and ethnicity differences, again, an entire presentation could be done on this one. But know that some people, especially if they're coming from a marginalized group, may have concerns about working from somebody from the like a privileged group, because they're worried, is this person going to provide an interpreter or expect one of my family members to interpret, which is not ethical? Do they believe in my humanity? Do they think that I'm deserving of services? Maybe the person you're working with is undocumented or not a citizen. It can stop them from reaching out for services because they're worried that somebody's going to think of them as less than. They want to know, will this person understand the nuances of my cultural identity, the ways that I think about family, the ways that I think about engaging in, outside of family help? Will this person respect my religious beliefs? Will they take me seriously? And then finally, rural communities. This one's especially relevant to like virtual sessions or telehealth. But rural communities tend to be very insular and very distrustful of people who are outside, especially if they are very outside of the community, as in like a telehealth situation. So is this person, do I know that I can trust them? Do we share values and beliefs? Does this person know that I don't have access to certain resources, and are they aware of the ones I do have access to? And will they make sure that my privacy is respected? We could do an entire presentation just based on cultural humility. So I will let it go for there, but if y'all have any questions, I'd really, really love to hear them. Here's one question. I was taken aback when I interviewed a patient and had the family member tell me, we do not have religious beliefs. And this question came in my intake interview. We were asked about cultural spiritual practices. I had to remain aware of my Christian beliefs to speak about God's grace. I would assume the patient was Catholic due to her culture. Yeah. So unless we ask, we may not know. And it's really peculiar to have to, especially we make that assumption because maybe the person, we thought they were Catholic. It's hard. It's really hard. Also, basically everything that I've talked to you about today is also available in our training materials for our volunteers. It's open. You can go to our website and download it. We are not stingy with it. We want you to have it. And if you want somebody from the Crisis Center to come and talk to anybody at your organization, we're happy to do so. Everything we do is free of service, or free of charge, even presentations. So I'm glad to help in any way that I can. And I was told that y'all would have questions, so please ask them.
So while they're thinking about that, what is the website where they can find the resources?
It is crisiscenterbeham.org. I can put it. It's basically my email address. Just put www in front of it. You can get information about our different services. They can find our volunteer training materials, links to other organizations in the community, pretty much whatever you need. And we're open 24 hours a day. So if you do give out the Crisis Center as a referral, know that, somebody's here all the time. So we may not have the exact program they're looking for. We'll get them connected somewhere. Baldwin County. So y'all have, in Mobile County, there is Lifelines Counseling. So they've got counseling. I don't think their line is 24/7, but they've got a crisis line. They've got rape response services. But then in Baldwin County, I forget the name of the rape crisis center that's there. So the rape crisis center has some of the resources that the crisis center would have. And if you want to call, you can call our hotline number, and I'll put that in there too, 205-323-7777. And we have access to 211's database. Yes, the Lighthouse. Thank you. But we can get you connected to whatever's in your area. And if there's not there are a couple of, there are only 3 like mental health crisis centers and not specifically rape response crisis centers in the state. So not all of our counties are covered, but it doesn't mean that we're not going to be able to help somebody. It just means that we don't go specifically to that county to do like outreach, but we still have access to resources. Olympia, thank you. Yes, Lighthouse for 10 years. I imagine that you probably had to go to like ACAR meetings and Alabama Coalition Against Rape. And so we probably know some of the same people, but they're great.
All right. Any other questions? We're a few minutes over, but I just want to make sure. No, you're good. You're good. I just want to make sure that there are no other questions as you're thinking, attendees. I do want to make the point before people start jumping off about the CEU, CMEs, CDE, CPE, all of those. And you will receive an evaluation link on Monday where you will do the evaluation. And then it depends on the group that you are wanting the CEUs, CMEs from. Some have requested, like MASA has requested just once a month I send that. So it really depends on the group. But I will, if you do have any questions, just please email me and I will be able to answer those. We have some upcoming webinars here, one tomorrow. And the reason why I had this one on Thursday is because the one tomorrow is just sort of an extension of this. It's more specific to providers in regards to pharmacotherapy, but it does have to do with telemedicine. I thought this was a good segue into that. And then we have 2 on addiction and the brain, which is 2 perspectives on that. So those are the rest of the ones we have in July. So we don't have any other questions. Then I want to thank our presenter. It was very great information. I hope you all got a lot out of it. And please follow us on social media. And with that, I will say good day.